राकेश, आपको होस्ट बना दिया मैं।
ओके सर, ओके।
हम्म। Hello.
Yeah, good evening.
Hello. Yeah.
Hello.
Good evening, sir. Good evening,
हाँ
sir.
बोलो जी.
Sir, today I'm going to present a laser overview.
Yeah, very good. Who's speaking?
Myself, Girraj Sharma, sir, from
Yeah, hi
Puttapatti,
Girraj.
sir.
Yeah, very good, very good. So you will talk a
Yes.
little bit on laser. Then we have Dr. Nanjappa. He will give us his expert
Yes, sir.
comments
Yes.
and lecture on the lasers. And Dr. Maheshwari sir will
Yes,
also
sir.
tell us about laser in BPH. Okay. So Giriraj, how many slides have you prepared?
Sir, I think 2025. I will finish it quickly, sr, within 10
Yeah,
15
no
minutes,
worries.
sir.
No worries.
Yes,
No
sir.
worries. So we'll just wait.
Yes,
Let Dr. Nanjappa sir join
yes,
in,
yes, sir.
and uh, once Dr. Hodedar is already there.
Is it my slide visible, sir?
Yeah, it's visible. It's visible.
Okay, sir. Okay, sir.
Let's wait 5 minutes. Gite sir is already joined, and
Yes,
we'll give
yes,
five
sir.
minutes, and then once Nanjappa sir joins, then we can start.
Yes, sir. Yes.
Yeah.
Good evening, sir.
Good evening. Good evening, sir. Good evening. We'll just wait 5 minutes, sir. I will just call Dr. Nanjappa sir, and then we can start.
Yes, sir. Yes, sir.
हाउ है सर औरंगाबाद में कैसा है बारिश हेवी रेन
बारिश चल रही है लेकिन नासिक में हूँ.
अच्छा आप नासिक में यस यस मैं भूल गया गुड इवनिंग महेश्वरी सर
Good evening,
Good
good
evening, sir.
evening. Good evening, Dr. Gite.
Good evening.
सर
Hiren, I
गिरिराज
don't know whether you are
गिरिराज
aware, Nanjappa may not be able to join today.
व्हाई सर व्हाट हैपेंड
Some family emergency.
ओके सर
Okay. So he just
So-
called me 2 minutes back कि तुम्हारा
Okay,
फोन
sir.
नहीं लग रहा है
अच्छा
and
सर
he will not be able to join.
नो प्रॉब्लम सर सो गिरिराज has prepared about 20 slides on laser sir let's hear him out
Yes.
and then we can give him expert comments and then we have got a small case kidney stone case
Perfect.
जी sir जी Giriraj, I think you can start now. The rest of the people can mute themselves.
Yes, sir. Yes. Yes, sir. Good evening, everyone. Today I'm going to present on a laser in a urology on overview. So, as we know, the laser, it is a term coined by the Gordon Gold. It is the L terms for light, A S and for amplification, S for stimulated, E for emission, R for radiation. So it's a light amplification by stimulated of emission of radiations. In 1960, the theory put to use by T.H. Maimon to produce first visible laser, that's called ruby laser, and Mulvaney attempted use in urolithiasis in first 1982. So this was the history when first this theory of spontaneous emission is given by the Albert Einstein 1917 and followed by amplified electromagnetic radiations and all. It's continuously going, and the first in vivo experiment in urology, it is done by the person, and first patient in urology by Mulvey and Beck. So it is the basic properties of laser which is differentiated from the normal light. This is the coherence. All that means all the wave of light together temporarily and spatially. The second is collimation. They all travel parallel to each other with no divergence in its path. And monochromicity. They all have the same wavelength of color. As we can see in this picture, that's clear cut differentiated that normal light having multiple wavelength or color, and it is that the light is not travel in a same path. They are not travel in parallel. So that's a differentiate between the laser and the ordinary light. So as we usually heard about the pulse laser or continuous laser, what does it mean? So it is basically, it's depending on how the excitation energy is applied and how the laser cavity configured. The output beam of the laser light is either pulse wave or continuous wave. Pulse wave means deliver the burst of energy which works well for the stone fragmentation, and it's more difficult to control during the soft tissue interaction. The same way, the continuous wave laser is a delivered output is continuous manner and it's a constant amplitude. It's allow for a stable and easy to control instruments. So, it's a classification of laser, either continuous and pulse laser. Continuous is a thulium laser, green light laser, diode laser, KTP and the YAG laser, thulium fiber laser, that's called TFL, and pulse laser, that's holmium YAG and thulium laser. It can be we can use as a pulse as well as a continuous laser. So we have to here I'm going to discuss only two lasers, which is we are commonly use a holmium and thulium. The holmium is properties wavelength is 2100 nanometer, completely absorbed by water within 0.4 mm of its fiber tip, and it's a thermomechanical mechanism of action, and it's a contact laser. So these are the component where the how this holmium laser will produce. So basically we can see on the right on the left side one box that's called laser cavity, which having two mirrors and one opening. That it's having one flash lamp, one yak crystal. Over that crystal the holmium ions were impregnated, and that light which is produced by the flash lamp, and it's gone through this crystal. So as we can see in this next picture, the figure of the figure A, which shows that light is produced by the lamp and it goes through that crystal, and that crystal that producing the photons, which is excitation, and producing the one light. That will light go, and again it is reflected by that mirror, and it will come back. The same process will happen again and again. That's called pumping. That's called process pumping, and then we can see in the figure of E. This is again happening, and then amplification. That's called amplification, and finally that laser comes throughout one opening. So basically, the concept was initially when the holmium laser came, it was have two limitations. One limitation, it is one limitation that that cavity generator, which having that too much radiation, that waves are dissipated, so that temperature is increasing. So that's why that cutoff was 30 watt or 30 hertz. That was the initial cutoff. So to rule out this limitation, they made a high power generator. So high power generator, how they made the multiple cavities, the same process which I explained, and those cavities, the rays will converge and that come out through the one opening. So this need a vapor compression refrigeration system to decrease the temperature. The same is a thulium YAG laser. It is a continuous wave laser. The wavelength is 2013. It is high absorption in water, low in oxyhemoglobin. Optical penetration is 0.4 mm and coagulation depth is less than 1 mm. That's what we are using as a thulium fiber laser. It's a basically is a alternative to holmium, which are using in the lithotripsy. Is a long thin silica fiber doped with a thulium ion. As the wavelength is 1940, operate in continuous or as well as in adapted pulse mode. So as I explained, it can be used in a continuous or adapted mode. So thulium fiber lasers, the diameter is 10 to 12 micrometer and length is 10 to 30 meter. Electronic pulse shape modulation. Does not use flash lamp, therefore a heat generation does not occur. This is a important feature, and this is a advantage over the holmium. There is no flash lamp. So in a holmium generator, we have to be much careful while transporting from one place to the other, because the chances of damage to that flash lamp is there, and there is a no though there is no coolant is required for to decrease the temperature. The forced vane ventilation is a cooling mechanism in the thulium fiber laser. So basically, it is a laser, as we can see, as I already explained, is it is coated with a diode laser over coated with a thulium ion. So laser pumping is achieved by the electronically modulated diode laser. A thulium doped 10 to 20 micrometer core diameter and 10 to 30 long silica fiber is used as a gain medium for generating the laser beam. So this is the second disadvantage of holmium, but we can see on the right A. The A picture was the holmium, what is this called? Spatial resolution. At a one point, uh, like the beam will be, it's having the lateral damage will be more on the holmium in compared to the in the thulium. There's a uniform laser at the output connector, which allow for the laser fiber as small as 50 micrometer. So the thulium laser require a less heat dissipation and can potentially operate as a high power range, more than 50 watt, or a high frequency range up to 2000 hertz with a forced air inside the generator compared to the water cooling as in holmium. And the architecture of fiber laser is insensitive to shock related damage unlike holmium. So let's talk about the laser fiber component. It's having one fiber core and one fiber jacket, and over the fiber core, one fiber cladding. So its laser fiber core can be ranged from 150 to 1000 micrometer. Largest is 550 to 1000 micrometer. Core for a rigid instrument, and smaller it's 240 to 270 micrometers. Size for flexible ureteroscopy. So fiber flexibility, 240 to 70 micrometer fiber core is 30 to 60 degree deflection loss. 200 micrometer fiber is 20 to 30 degree deflection loss. For maximal deflection, 200 micrometer should be used. So one type of is ball tip fiber, allow easy passes of fiber through the flexible scope by sliding easily, can be inserted into flexible scope even in a deflected position, which is not advisable for flat fibers. So these are the different kind of fibers. So as we know, application of laser in urology for soft tissue incision like urethral stricture, posterior urethral wall, endopilotomy, bladder neck contracture. This can holmium YAG laser, ND YAG laser. For resection ablation like BPH and TCC, we can use. So urolithosis, basically the laser lithotripsy was first used, as I explained, as I already told, is late 1980. And like the mechanism of action is plasma formation between the fiber tip and the calculus develops an acoustic shock wave, which shock waves that disrupt the stone along the fracture line. So as we usually heard about painting, popcorning, and fragmentation. So painting is place the fiber in contact with the stone and brush back and forth across the stones, like we are painting with a brush. So popcorning is place the fiber near the stone but not in a contact with the urothelium. Deliver the intermittent laser burst causing movement of stone and fine fragmentation. Fragmentation is what mean place the fiber in contact with the stone, pin against the urothelium and focus the fiber on one point until the stone breaks. That's called fragmenting. Chipping it just like in the edge of the stone, we contact the fiber and hold steady as a small chips fragment off. So these are the usually we heard or we read about, like dusting. We have to use low
Is Giriraj on? Because I am not able to hear anything.
Yeah, the audio is lost.
Yeah. Giriraj, your audio is lost. So any questions till Giriraj joins again? We can have any discussion, any doubts? So what Giriraj was showing that each generator usually generates about 30 watts of energy. Therefore, these machines are labeled accordingly. They have actually what they say is a 100-watt laser. It's actually not 100 watts but 90 watts. And then they tweak the software and they make it 100 watts. And sometimes they sell machines as 35 watts. But you must be aware that each generator is only 30 watts in holmium. So depending on the amount of generators it has, it is either 90 watts or 120-watt laser or 30-watt laser. Secondly, the fiber, the protective mechanism on the fiber is not the blue coating. The blue coating is just a jacket. And earlier we used to strip that jacket and use the fiber. Now we cut it flush along with the jacket so that is easily identifiable. However, that blue jacket is not going to protect your endoscope. It is just for identification. I think Giriraj has prepared it quite well.
Sir, is
Maybe
holmium laser a non-contact or contact laser?
Contact.
So yeah,
So you see, holmium laser can work both in contact and non-contact mode.
absolutely. Yeah.
When you are doing dissection in the prostatic fossa, you predominantly work in a non-contact mode. Even for stone fragmentation, if you, like he had shown, that when you need to fragment the stone, you would touch the laser fiber to the stone, pin the stone against the wall, and then fire so it will break. But if you want to do a pop dusting, then you don't touch the stone, you just keep it in a small calyx. The laser fiber is kept in the center of that calyx and you keep on firing, and just by the laser energy, the stone gets fragmented. Especially the newer innovations, which is the Moses technology, that works beautifully with a non-contact mode. Means you can be up till 1 millimeter away from the stone and still cause a reasonable dusting of the stone.
So what usually me and Nanjapa sir say, and Nanjapa sir usually explains the students very well, that it's like a hammer, you know. So the long pulse and the short pulse we remember like a hammer. So the short pulse is, you know, you're giving a short but a very powerful stroke of energy. So therefore it fragments, it breaks into multiple pieces. And long pulse means we keep it a little far away and then just little bit we are giving the energy, and that's how the dusting and pop dusting is actually occurring. So sir said very well. In fact, even in prostate, when we start earlier in the initial learning curve, we tend to touch the prostatic tissue. But as we start doing many and more cases, we understand that the dissection is happening beautifully when we are just little bit away from the tissue. Similarly with the stones, the more you touch it, the bigger fragments it will happen. But if you're just little bit far away, then it's working very well.
I think Giriraj has joined back.
Yes, sir.
Yes, sir.
Haji Giri.
Sir, what would be the settings for like what you recommend, sir, in the ureter, whether we have to use this
So just
laser?
go back
Because
to that slide where you stopped. You know, you were showing that long pulse and short pulse and multiple settings. So
yes,
once you finish that, then we'll discuss one by one
uh,
whatever points. Yeah.
yes, sir, yes, sir. Is it visible, sir?
Yes, yes.
1 minute, sir, 1 minute. These are the questions, sir, which
No, that last slide, which where we lost you, was that fragmentation, long pulse, short pulse. Short pulse is fragmentation, and long pulse is the popcorning and dusting. So finish
oh,
the
that was the
presentation.
oh, okay,
Ha.
okay.
Yeah,
I
yeah.
thought,
Now
sir,
from here,
okay, okay,
from here
okay,
onwards.
okay.
Yeah.
Okay, sir.
Then we will
Uh,
take the questions.
so yes, sir. Yes, sir. So painting is the to place the fiber in contact with the stone and the brush back and forth across the stone and ablating the layer by layer. Chipping is just we have to go to the edge of the stone and hold that fiber in contact with the stone steady to small chips at the fragment of. Popcorning means we have to take the stone fragments in one calyx and then place the fiber near the all stone but not in a contact with the urothelium and deliver the intermittent laser burst causing movement of stone and fine fragmentation. Fragmentation is place the fiber in contact with stone, pin against the urothelium and focus the fiber on one point until the stone breaks. That's called fragmenting. So that's what usually book says that for dusting we have to use low energy high frequency around 0.5 uh, joule and 50 to 20 hertz. Fragmentation high energy low frequency and popcorning both high energy and high frequency we are using. Moses technology basically which was in that rather than delivering a one pulse. So one pulse when we deliver it form a vapor bubble and then the energy will dissipate it and it's absorbed by the water. But in Moses technology we rather than delivering a one pulse we're delivering two pulse. So one pulse energy to form the vapor bubble and the second pulse deliver the rest of the energy through the already formed vapor channel. So that's help to loss of the energy dissipation. And it will minimize the stone retropulsion as well. So it can be it other use in the benign prostatic enlargement. It is the laser tissue interaction that include the coagulation and evaporation. Coagulation happen the tissue temperature 100 degrees Celsius and evaporation temperature up to the 300 degrees Celsius. As we mostly use a holmium laser, so it is can be enucleation, ablation, or holmium resection of the prostate. So that's all, sir. I'm not go in detail. The sir told me just 10 to 15 slides. I made 20, 25. Yes, sir.
No, you have done very well, Giriraj, and you have given a good
Thank you.
overview.
Thank you, sir.
Very good,
Thank you,
very
sir.
good. And nicely you have covered. So last time sir had asked about Moses technique. So exactly you have explained that
Yes,
first one bubble is released and then the energy hits that already formed bubble, and that's how loss of energy is prevented and retropulsion is also prevented and energy is focused onto the stone. That's
yes,
very good. Now, for dusting, what you have shown, so initially we were doing very low energy and high frequency, but now
yes, sir.
when we are using thulium laser, for example, when the machine starts, the energy is
Yes.
1 and 6. Even if you use that 1
Okay.
and 6 energy, which is totally just 6 watts, you can achieve very good dusting by just keeping a little bit away from the stone and not forming big fragments. And in the
Yes.
kidney, we go from periphery to the center. And in the
Yes.
ureter, always remember that from the center towards the periphery. But it's
Yes.
very essential not to use, dusting and popcorning in the ureter. Just use
Okay.
your fragmentation mode and keep the energy as low as possible. Even
Okay.
6 watts to be used very, very carefully in the ureter. Now there are a lot of recommendations saying that do not use thulium fiber in the ureter. So better to use whole beam, but we cannot have multiple machines. So it is better to be a little bit careful and use the energy very carefully and not cause any damage and strictures formations.
So
So
if the
for
person,
dusting, so
yes,
for
sir.
fragmentation, also that is a good energy, higher energy and lower frequency. And for popcorning, we can do like 0.10 and up to 100 hertz. But now even that is not recommended. So they're saying maximum even frequency you don't go above 25. That is what
Yes, sir.
Professor Olivia Traxler has recently recommended, not to even exceed 25 watts,
Yes.
25 hertz also, even frequency not to exceed more. So definitely the total energy to be used in kidney should be restricted to 15-20 watts, and in ureter
Yes.
about 6 to 8 watts max.
Okay. Thank you, sir.
And what were the other questions? That ureter we have answered.
Yes, sir. Sir, if anyone wants to buy a machine, which one like in a which one you advise to be like holmium or thulium
So
laser
this
in a
this
stone machine?
debate is always there in every conference, and
Yes,
those who swear by holmium still swear by it, and those who are happy with the new toy are swearing by the thulium fiber laser. But
yes,
as of now, I feel even Pankaj sir will agree with me that holmium laser has stood the test of time, and
oh
it
yes,
has been safe even in the ureter. So
okay,
if you are starting your practice and if you think, because see, with thulium fiber laser, we are not using any of those 1000 frequency and 500 frequency.
yes, sir,
We are just
yes,
using very, very minimal settings. So if you want to buy one laser and if you want to
yes,
even have good tissue effects, then I think holmium is a good choice. However, we are not here to sell
yes,
holmium or thulium. We are just having a academic discussion. So, but for your prostate and
yes.
strictures, holmium should be very good.
Sir,
So a
Thank
sir,
you.
lot of centers in US now are, yeah, Dr. Gite, please go ahead.
same question was is asked by today by government of Maharashtra to me. Ki, if they want to purchase the laser, so what laser they should purchase? So this class is again I was for me already suggested a holmium. But sir, my simple question should it be a 150 or anything like that? ऐसा कोई ज्यादा रहे
No,
तो
sir. No, sir. Quanta laser is a very good laser. I think 60 watts is many people are doing prostates now with 60 watts. I think Pankaj sir will also agree with me.
given a chance if government is ready to purchase at the best, so 150 is
Yes.
better, yeah, 100 is better, yeah, 60 is better.
100 is more than enough, sir. I feel. What the bigger lasers are going to do is only your speed, sir. Nothing else.
So the advantage will be when you are doing very large prostates. So if I'm doing a say more than 150, 200 gram prostate, then probably higher frequency helps me more. For
Absolutely.
smaller prostate, there are ample studies, sir, that if we take prostates up till 40, 50 grams, whether you do a low power HOLEP or a high power HOLEP, even the time for enucleation efficiency, everything is nearly the same.
Same.
Rather, with low power laser, they have said that there may be advantages of lesser postoperative pain because less energy gets delivered to the capsule. So the post-op pain and probably urgency may be a bit lower with low power laser. But if you are going to buy one laser and if finances is not the issue, the major advantage of 150 watt will be you can step up the frequency to around 60, 80, and that would be important when you are doing dusting in the kidney. So, Vice, I would want to just say here that the settings that Dr. Hiren told you were for TFL laser. For holmium laser, things may be marginally different.
Yes.
The heat generation in holmium laser is not as high as TFL laser. So when I'm doing holmium laser, even if I step up the frequency to maybe 60 or 80, does not make much difference. I can go to the energy as low as 0.1. So 0.1 into 60 would give a very good dusting. Remember your laser settings. There is a very good word which is given, which is called as taste the stone. Means instead of test the stone, you taste the stone by laser. Once you
Yes,
start,
sir.
so my standard would be I would start with say zero point 0.4 joules and maybe 30, 40 hertz. See how the stone is fragmenting. There are some stones which are very soft, say Hounsfield unit 350, 400, predominantly uric acid stones. They tend to break very rapidly at low energy also, at zero point 0.4 energy also. So in those patients, I would step down the energy. But there could be calcium oxalate stones or calcium phosphate stones which need higher energy to fragment. So there you step up the energy. So you start at a low energy, moderate frequency, and depending on how the stone is moving, you can increase or reduce the frequency. Now, in your presentation, what I have one small error I would say is that there is
Yes,
a mix up between thulium laser and thulium fiber laser. Like say
yes,
your last question, holmium versus thulium laser in stone management. Thulium
Yes.
laser is not used for stone management.
Uh, Thulium laser fiber. I'm sorry.
Yeah,
Yes.
TFL.
Yes.
Make it
Yes.
very clear.
Yes.
You
Yes.
see,
Yes.
there is a new innovation in thulium laser, which is called as Revolix laser,
Yes.
where thulium laser has also come in a pulsed mode format, which can be used for stones. But the
Yes.
conventional thulium laser is a continuous wave contact laser, and
Yes,
that
sir.
not work for stones.
Yes.
So what sir is saying is when we say thulium laser, now we refer to the old laser,
Yes,
the thulium yug
Yes.
laser.
Yes.
And
Yes,
when
sir.
we say TFL, then we refer to the thulium fiber laser which we are using for
Fiberless.
stones.
Yes, it is. I'm
So
agree. Yes.
that may cause a mix up. So just be
Yes.
clear on that. You say thulium yug laser and thulium
Yes.
fiber laser.
so
Yes, sir.
TFL and thulium laser make this distinction very clear. Thulium
Yes.
laser is only a soft tissue laser to be used for stones. The advantage of thulium laser, it's a brilliant cutting and a coagulating tool. So
Yes.
sometimes faster than HOLEP for enucleations and resections. Disadvantage, gives a lot of charring. It is very difficult to identify the tissue planes. So the procedure becomes a more difficult, and at best it may end up being a channel making laser and not a enucleating laser. For stones, it is holmium versus TFL.
Yes.
Okay, again now popcorning, the term is pop dusting or pop fragmentation. You
Okay.
see, there are two completely poles apart concepts for popcorn settings.
Yes.
There is a setting where they say high energy, medium frequency or high frequency. So like in my setup, I would start with 1.2 joules and 15 hertz. That would be mainly for pop fragmentation. These are for when the stones are high HU stones, so stones more than 1000 HU, and when there are some fragments in a small calyx. Remember, popcorning cannot happen in renal pelvis or in the ureter. It needs to
Yes.
happen in a small closed
Small
space.
cal.
So
Yes.
you push the stone in one of the calyx, either upper calyx or middle calyx, and there you can do popcorning. So high energy, medium or high frequency would be pop fragmentation. Low energy and high frequency would be pop dusting. So stones
Yes.
which are low HU stones, there you would use low energy and high frequency.
Yes.
So exactly what sir said just now and what he said 5 minutes back, just put both of them together. So when you start with the low energy and high frequency and you see that nothing is happening, that means the stone is very hard.
Yes,
That's
sir.
where sir is saying that you should put the settings as 1.2 and then the frequency as 15. Then you will see that okay, something is happening. So that is what sir means by testing the stone. So
Testing
if
the
it's a
stone.
very hard stone and you have started with low energy and high frequency, and you're saying that you have taking so much time, but actually nothing is happening, the dusting is also not happening, then you need to increase your energy because then it requires more energy to break it down.
Yes.
And then
So
once you
one more.
remove those fragments and then you go into low energy and high frequency, then it will become very tiny pieces.
Yes, sir. One more doubt, sir.
Ji.
Recently, I attended one conference, and they're saying that rather than that joule setting, rather the increased temperature in the calysis, that is because of more frequency.
That is
So
what
you
I
have
said.
to.
No, that
Yeah.
is what I said that Professor Traxier said that
Yes.
initially we were talking of going very high, but now they are saying that please do not go more than 25 watts. Now that has also changed. It's coming to 15 to 20 watts total energy.
Oh, okay. Okay, sir.
So we don't have any devices at the moment to check temperature in the kidney.
Temperature. Yes.
And once in one of the conferences, only Kandarp sir also demonstrated that what happened is that patient was having severe pain post-operatively,
Yes. Yes,
and
sir.
he was saying that everything is fine, CT is fine, stent is in place, but why is the patient having so much pain? So he went inside after for 24 to 48 hours, and he
Yes.
said I was surprised, and he showed that video that there was complete sloughing of the pelvic hallucinal system.
Okay.
That was the reason of the pain. So
Yes.
as more and more work you do, we realize that temperature, we are not able to assess what is actually happening. And therefore, last time Professor Traxler used the terminology, he said, you guys are baking the kidney.
Yes.
So we have to be very careful with these new devices till long-term studies come. No?
So understand
And
what
sir,
happens in high frequency. Am I on?
yes,
Yes.
sir.
So in
Yes,
high
sir.
frequency, what would happen is when I am working at low frequency, there is a higher chance that every pulse gets delivered to the stone.
Yes.
Okay, I would be no more near the stone and every pulse gets delivered to the stone. But at a high frequency, a lot of pulses get delivered only to the liquid medium and not exactly to the stone.
Yes,
So
sir.
it is the high frequency which causes more rise in temperature of the water. Again, the water absorption coefficient of TFL is nearly 4 times that of holmium laser.
Yes.
Okay, so there is also one more term which is called as optical penetration depth, OPD.
Yes.
Okay, optical penetration depth means how much laser energy, means at how much distance two-thirds of laser energy gets lost. Okay, so the
Yes.
optical penetration depth of TFL is very, very low. So
Very low.
for TFL to work, you need to be quite near the stone. Distance mode is very difficult in TFL.
Yes.
Yes.
Distance work
Yes, sir.
mode works very good in soft tissues, interestingly.
Yes.
For
Yes,
prostate,
sir.
distance mode of TFL works very well. For stones, you need to be very near, because if you are at around 1 millimeter from the stone, the amount of
Yes.
energy delivered will be much less than 0.4% of the energy. The
Yes.
advantage of this is that when I have a higher optical penetration depth, means more energy gets absorbed at a shorter distance, then I would be working more as a contact mode. Less energy gets delivered to the stone, so less fragmentation and more dusting. And also the risk of damage to the surrounding structures, say maybe the guide wire or the basket that is there, will be very low. But if it's a higher optical penetration depth, means higher length where the laser energy remains maintained, then the fragmentation would be higher if I go near the stone. For dusting, I'll need to be slightly away from the stone, and there is a theoretical risk of injury to surrounding structures. So there are pros
Yes.
and cons of everything.
Uh, so one more doubt, sir. What irrigation method we are using? Like in our hospital, we are like manually in 50 cc syringe according to the like visibility we are pushing the saline. So
So
what's the
again,
ideal?
the only person using this method is Kandap sir, where he is flushing. But
Yes, sir.
according to me, it should just be gravity. So
Okay.
the simplest and easiest way to make an irrigation system of yours is to use a TUR set, which gets good
Okay, sir.
flow, attach
Yes, sir.
it to a pathfinder, and attach a 100 centimeter extension. Now, this
Okay, sir.
pathfinder, you can put it on the leg of the patient. So you get, anyway, we give lithotomy. So on one of the legs, you get the irrigation system, fix the pathfinder there. So the guy
Yes.
assisting you from behind can just put his hand on the pathfinder and give you irrigation when required. Now, this
Yes, sir.
forced irrigation is only required when the channel is occupied. Otherwise, your irrigation is coming nicely and you should be able to see very well. Without any, if the
Okay.
laser fiber is inside, the irrigation will be fine because laser fiber is only 200 microns. But the minute a basket
Yes.
comes in, your irrigation becomes literally zero. Therefore,
Okay.
last time also I said you need to have a 1.7 French basket, not a 2.2 French basket. 2.2 French will
Okay.
completely close your channel. So 1.7 French basket, and then when required, then you use the pathfinder. So this is one of the
Okay.
best ways to have a irrigation system. This is cost effective because TUR set hardly costs anything. 100 centimeter extension hardly costs anything. The purpose of the 100 centimeter extension is that the pathfinder is not hanging on your scope. So the weight of the pathfinder or the liquid is not pulling you down. And
Okay.
even if your assistant is, feeling a little tired or sleepy or something, he will put his weight on the pathfinder and your scope will get pulled to one side. So best is to
Yes.
put the pathfinder on the leg and then have the extension coming to your scope. It is very light. Nobody's pulling you. There is no drag on the scope when you're operating.
Yes.
Yeah.
Again, about irrigation, understand few more things. You see, why do
Yes, sir.
we need proper irrigation? You need proper irrigation so that your vision remains clear.
Yes,
You
sir.
need proper irrigation so that the ureter remains open, it doesn't collapse. Okay.
Yes.
And most importantly, you need proper irrigation so that the temperatures in the kidney do not rise. At
Okay.
zero irrigation or at very low irrigation, the rise in temperatures would be much rapid. So for reasonable maintenance of temperature, the amount of irrigation needed is around 30 to 35 ml per minute. Now that will be
Okay.
possible without a equipment with gravity when there is no instrument in the channel. But when there is an instrument in the channel, then it would hamper the irrigation dramatically. So that is when some mode of pressurization is necessary. And as Hiren said, that Pathfinder is an ideal way of doing it. But if you do it with a syringe, yes, you will need one assistant who understands the procedure, and it can be done that way also. But
Okay.
So
strictly try and
regarding
avoid
your
those pressure bags. You see, the disadvantage of pressure bag is that they are giving you continuous high pressure.
Yes, sir.
That is not what I want. I want high pressures only when there is a equipment, there is a disposable equipment in my scope, or if I have some problem with the vision. Continuous high pressures will lead to significant high intrarenal pressures.
Yes.
So there are several irrigation systems available. One is made by Roccomed. It is called Traxer Flow, which is not available now, but earlier it was not available. Now it is available by Roccomed. That is designed by Professor Oliver Traxer, which has a pump like a Pathfinder, and it has a small
Okay, sir.
chamber which has to be filled so that it is airtight. It is called Traxer Flow. Then there is one more irrigation system which is same like Traxer Flow, which is available by the Cook company. Again, it is out of stock right now, but it has the same one chamber above, like and one the chamber for irrigation. Then there is a syringe available from Boston Scientific, which has got a spring action. So that syringe which you are using, the Boston Scientific
Yes.
syringe is that when you press the plunger, it automatically refills. You don't have to pull.
Okay.
So you
Okay.
press the plunger, again it refills. Again you press the plunger, it refills. So it's a very nice device. It is available from Boston Scientific. And
Okay.
the last is your self-made irrigation system. And then in countries which are cold, like in Europe, we had a Rocco made irrigation chamber wherein they will put the irrigation bags inside the chamber. That is to heat the fluid to body temperature.
Okay.
That is also available. But usually in our country, we don't require it. Somebody has asked a question that if there is a stone entrapped in the basket, what would be the laser settings? So we have to keep the settings as low as possible because any energy is going to break the basket. So
Yes.
you have to be very careful that you don't hit the basket, otherwise it's going to break. Now, this is a
Sir.
situation which can happen with anybody that when they are using a basket and they can get trapped inside the ureter, either when doing RIRS or when you are doing an upper ureteric stone. So this trick, everybody should know that even in a URS scope, even in a 6 French URS scope, if you are using a 1.7 French basket, along that side of the basket, you will be able to place a 200 micron laser fiber. So if you are trapped, in the earlier days, we used to cut the basket, leave the basket inside, come out, go by the side of the basket, then break the stone, then get the basket out, stone out. That is how we used to do. But now the trick is that if you are with a 1.7 French basket, even in RIRS, laser fiber will go by the side of the basket. Even in your URS scope, laser fiber and basket will go in the same channel. So you must know that, then you should use the basket. Then there is also a scope available from Wolf, which has got the basket and the laser fiber together. That means the laser fiber comes in the middle of the basket.
So basket has a channel for laser fiber.
Yes.
So is there, may I ask some question regarding
Yeah, please go ahead. Yeah.
flexi?
Yes, yes, go ahead. The next we are
Uh,
going to discuss
yeah,
flexible only.
yeah, yes, sir.
Yeah.
Sir, what will be like initially when we in, so like in primary cases, what things like it should be cut off like that if it is 7 French is not accommodating in the ureter, whether we have to be calibrated with like semi-rigid dilated, like
So what is the
semi-soft
usual?
Teflon
So what
dilated.
is the usual teaching? So okay. So which ureters will be compliant? Any previous history of URS?
Yes,
That
sir.
ureter should be usually compliant. Old
Yes,
age
yes,
and patient who are pre-stent,
yes, sir.
or the patient has got a stone in the lower ureter. These ureters,
Yes,
you are sure that mostly these ureters will be able to take your access sheath and flexible inside.
yes,
Now,
sir.
in some cases, what happens is that you feel that the ureter is tight. So, what is the usual
Yes, sir.
teaching? If a 4 French URS is going with difficulty, put in a stent and come out.
Yes, sir.
If your 6 French URS is going in, usually it will accept the 9.5 or 10 access sheath. Now, when
Okay.
you're using fiber optic scopes, your 9.5 access sheath is okay. But with the digital
Yes, sir.
scopes, you require at least a 10 French access sheath. So sometimes it happens that 9.5 is going in, but 10 French is not going in. Very rarely this
Okay.
happens, but it can happen. In those kind of cases, you may have to backload and go in and do it the case. However, if the stone load is big, I would still say that to stent it and come back at a later date, that is a safer option. So
Yes.
usual teaching is that if your
Some
6 by 7.5 is gone in, the 9.5 to 10 access
yes,
sheet
sir.
goes in. If your 10 French, you are
Yes,
8 French URS is going in, then your 10 and 12 by 14 access sheet also would admit.
yes, sir.
That is what
Sometimes,
usually.
sir, that yes, sir. Sometimes the six French scope we can able to negotiate, but the sheath will not cross even just it cross beyond the VUJ and then it stuck. So in
So
that case,
what is the meaning of 6 by 7.5? Your URS is thinner in the front and little
yes, sir. Yes,
broader
yes,
behind,
yes,
right?
sir. Yes,
So
yes,
actually,
yes,
if
sir.
you have a camera looking at what is happening to your URS and VUJ,
Yes, sir.
vesico-ureteric junction, you will see
Yes.
that there is blanching of the vesico-ureteric junction. They have done
Okay,
some
sir.
studies wherein they have put a suprapubic and seen from above what is actually
Yes,
happening. So
yes,
actually, if
sir.
your URS is not going in completely, therefore I said the URS scope should go in completely. If it has gone in
Okay.
completely, then probably it will admit your access sheet. Now another thing that
Yes.
happens is many times we are reusing the access sheets. In those cases,
Okay.
you will find a difficulty. But if you use a brand new access sheet, it may go in. Now, there have been some instances where I have not been able to put the access sheet all the way up, but midway, if it is going, then you use a shorter length of access sheet because at least that will give you some stability to do RIRS. But
Okay.
with all these things, it requires experience. So, if I would say that if the ureter is tight, please tend and come back, you will be safer and you will be much better with the patient next time.
Yes.
Hey, hi Hiren.
Hello, sir.
Hiren, and
Good
I
to have you
Pankaj.
here.
Yeah, there may be some background noise, but just two questions. Number
Yes, sir.
one is how much time maximum one should spend using the laser to avoid any major complication? And number two, is it necessary to popcorn all the pieces, or we can just leave behind big pieces and the clearance will be equal?
So, first question, according to me, sir, any endourology procedure should be not exceeding more than 60 minutes. However, in difficult stones, like when we do complex PCNLs and larger stones, we sometimes extend up to 2 hours. But according to me, the safe time is 60 minutes, maximum 80 minutes is what I would say. Because we have to understand that the devices are in the ureter also for that much time, sir.
So
So
there is a
ureter,
study done at Nadia where they have seen that the risk of infective complication goes up when the
yes, sir.
procedure goes beyond 60 minutes.
Correct, sir.
So
So my
60 minutes
personal,
is a very good time to reassess. Means that is
absolutely.
the time I would see how much time I am likely to need more. If I'm likely to need maybe half an hour, 40 minutes more, then probably it is safer to stage. Maybe I'm just in the last part of my procedure, I want to extend by 5-10 minutes, probably I'll continue. So at the end of 50 minutes is the time you reassess whether you want to continue longer or give it a stage.
So I'm
And
happy that the
about
study is
the fragmenting,
coinciding with my experience, that I feel that above 60 minutes, we have to think, we have to be a little careful. Yeah. Second,
and
sir,
about the,
regarding the
yeah, please go ahead.
fragmentation, sorry, regarding the popcorning you asked, sir. So I think, sir, if the ureter is nice and compliant, and if you have done a good popcorning, usually most of the fragments clear out. But then you have to give it time, sir, about 2 to 3 weeks. So before we had the fans or before we were doing dusting, initially all the cases we were doing popcorning only. And those, if the popcorning is done properly or the pop dusting actually, what the right terminologies, then it usually clears out the fragments. But however, sir, I have most of the times what I have done is I've used a 5 French stent, and I feel that it really helps rather than a 6 French stent. Was that sir's question? I don't
Yeah.
know.
Yeah. So yeah, the thing was
Yes.
that earlier we were doing ESWL,
Ji,
and
sir.
in ESWL the fragments used to be like 3 millimeter, 2 millimeter, 4 millimeter, and we have
Yes.
seen that most of that used to clear. So
Yes,
here
sir.
also, if you leave behind little larger fragments, I think still you have got a good scope that it will clear. So is there
Yes.
any study on that?
So,
Sir,
sir,
now most of the studies are actually concentrating on absolutely fragmentless RIRS. So they are actually now concentrating on saying that no residual fragment is accepted. So the studies are more focused towards that right now rather than how the fragments will clear.
Clearance of a small fragment is better or dust is better?
Dust is definitely better, sir. At the outset, sir, you should start with dusting. At the end, definitely you will be left with a few fragments. But then it's easier to manage those fragments rather than managing bulky debris. This, even the cruise study, which was done way back in 2011, has also said that there is no role for bulky debris. So at the outset, sir, we should start with with dusting dust as much as possible. At the end, sir, you will reach a stage where the stone is going to break into some pieces, no matter how good dusting you have done. But it is easier to manage those fragments at the end and have a better clearance. But if you start fragmenting right from the beginning in a bigger stone, you will have a lot of bulky debris. Unless you are using fans and getting out some of the fragments, then it's a good technique.
Is there any study which shows that larger the stone, longer time it takes to clear up, so that you should keep the DJ stand little longer in a bigger stone, or
So,
it is common for everything?
sir, now what they are saying is, sir, what earlier we were doing size of the stone, they are saying that don't just think about the size and go in, because it may take much longer. You may think that it is a 2 centimeter stone, but actually the volume is 4 centimeters. So they are now telling to have the actual volume measurement of the stone. So we have to ask the city people to give us the volume measurement. And regarding the city Hounsfield unit, also use the bone window and get the actual Hounsfield units. So if there is a larger stone burden, then definitely we have to talk about staged RIRS rather than trying to do it for 2 hours and 3 hours. Large stone burden.
so just to complete what Hiren had said, that you would initially start with dusting. In the end, you would create few fragments, and that's the advantage, because at the end, I want to pick up few fragments for stone analysis.
Yes, sir.
So dust maximum stone, in the end, make few fragments and pick them up. But if it's a hard stone which doesn't get dusted, or if you are trying to fragment the stone, then always keep an excess sheath and try to pick up maximum fragments. Because that concept of clinically insignificant residual fragments is gone long time
It's
back,
absolutely gone
and there
long
is
back.
nothing clinically insignificant. Even
Yes.
fragments as small as 1 to 2 millimeters, the risk of patient coming back to emergency is much higher than when you make it completely stone free.
So I tell my patients, sir, unless you have made it stone free on day one, I tell them that at 3 weeks we'll do a checkup. If at all there is any fragment left, it is better to just do a check URS, check RIRS at the time of stent removal. It is better to do that rather than leave a fragment.
Probably do a plain CTKB, a low dose plain
Yes,
CTKB.
yes, sir. Yes.
And if
Even
that
they
is
say
clear, then probably the
sonography
second stage
and
RIRS is not needed.
correction. So most of the times to avoid the CT, I have a endoscopic clearance documented, and then I'm sure that I don't need a CT.
So, Pankaj, is there any study or have you found out anything that if you give Lasix, then it will decrease the temperature of the URS, I mean, during RIRS laser treatment?
Lasix?
Yeah, so that it increases the urine output in the kidney, and because of that, like irrigation, it decreases the temperature. Is there any study like that?
No, sir, there is no such study. But they just finally say that the total irrigation should be more than 30 ml per minute. And we need to make a balance between the amount of irrigation, your vision, and the temperatures and the pressures. So all these things are interlinked. If you have a very good irrigation, your vision will be good, but your pressures will rise. That would increase the risk of infection. So overall, you need to balance. Means there was a time when I would often say that ureteroscopy and RIRS are better done under suboptimal vision, so that the irrigations are low and we don't make high pressures. But recent studies have shown that low irrigation leads to higher temperatures. So optimum irrigation and optimum pressure is acceptable. So if you are doing by gravity, keep the bottle at around 80 centimeters and intermittently keep on giving high pressure by whatever technology you have to clear the dust or to have a better view. But no continuous high pressures.
Secondly, sir, Lasix I use very carefully. In fact, I use it only towards the end in RIRS, URS, PCNL, TURP. Most of my cases I use Lasix only at the end of the case, because there have been studies which have shown that when bladder gets full, so the intrarenal pressure is also high and drainage is affected. So I don't use Lasix anytime during starting of the case or during the case. It's always at the end when the catheter is in, just to flush out the kidney as well as whatever extravasation, if at all, has happened. So that is when I use Lasix. I usually don't use it at the beginning. Somebody has asked any role for balloon dilatation. So I think most of us don't do it. And I think that was something which was done in the past when we had 12 French URS and we used to do balloon dilatation. I don't feel that there is any role for forceful dilatation. You're just tearing the ureter, and that is just going to heal by fibrosis. So at least I don't use the balloon.
Pankaj, the question is whether RIRS and this laser should be used with a general anesthesia or under a spinal anesthesia. What that is number one, and number two, the temperature is generated more because of the frequency or because of the energy.
So the second part we have discussed, that it is the frequency which is more important and not the energy. Obviously, energy is also important, but frequency plays a much bigger role. And coming to anesthesia, sir, it should always be done under general anesthesia and controlled ventilation, because it is easier to fire a static target rather than a moving target. With breathing, the kidney would move, the stone would move, the laser will not be able to focus on the stone properly. So if you have controlled ventilation, your anesthetist can give you 10-12 seconds of apnea when you fragment the stone. Then he would breathe for a couple of seconds. When you give a break, let the system drain out so pressures don't go up. The irrigation fluid comes out, small fragments come out. You restart the procedure, the temperatures don't go up. So intermittently, me doing laser and giving break for breathing helps with multiple ways. My target remains fixed. my irrigations are better, my pressures don't rise, fragment
Temperature is
clearance is better.
controlled.
So all advantages of general anesthesia, sir.
And temperature is
Understandable, there
also
is a
controlled because
restriction
you
of
are
RRS, but then you need a patient who will cooperate with you, or you will need to time your laser fragmentation with his breathing.
Now, Maheshwari, you have used thulium also and you have used holmium also.
Yes.
Compared to these two, which causes more temperature and chances of more complication?
Sir, temperatures are definitely more with thulium laser. Not now when we have started using thulium laser at a very low energy and low frequency. But initially when thulium laser was proposed at maybe 500 and 150 frequency, that time the temperature rises were astronomical. If you see, the amount of strictures that we see in the ureter has suddenly gone up in last 4 or 5 years since the time TFL has come into market. So any energy, if we don't use it properly, will cause us harm. If used well, every energy is good. So if you know the limitations of TFL, that the frequency and energy both need to be low, and you need to take care that you don't fire near the ureteric wall, then the risk of injury would be very low. Again, for TFL, there is one principle which is called as 5 second on, 5 second off. So you fire for 5 seconds, give a break for 5 seconds. In this 5 second with the irrigation, the temperatures would come down again. You can again fire. So continuously firing the laser, the temperatures would again go up.
that is why I added to your point, sir, when you said that when we're doing in general anesthesia, when we are giving it a break, the temperature is also controlled because
Yes,
of this technique.
absolutely.
So now coming back to the same thing, if there is a larger stone, you will like to do it with a low frequency and load that is totally low energy and a longer time, or you will like to finish it faster with the higher energy and higher frequency.
Sir, we need to define larger stone very well. Means, as Hiren has very rightly said, that now is the time where we should be talking about the volume of the stone and not the size. Because a 2 by 2 by 2 will not be same as 2 by 1 by half or 2 by half by half. The volume of these three stones will be dramatically different. And obviously, when we are doing dusting, we are working more on volume than on the size. Now, if the size is very big, if the stone is very hard, probably mini PCNL should be chosen instead of RIRS. Choose a stone which you can finish in 1 hour of laser time. So that is a decision you need to take based on your expertise, the equipment you have, and what your learning curve status is. So in my practice, sir, I try not to go for stones more than 15 millimeters for RIRS. Rather, even 15, I am sometimes uncomfortable. I would choose 15 around only when the HU is much less than 800. But if it's a 1200, 1400 HU, then even 12 millimeters will take a significant amount of time. So there is no single answer for this. Everybody needs to give his own answer as to what he can manage in 1 hour.
Is there any algorithm which says that the hardness of the stone, size of volume of the stone, and the frequency, I mean, and the energy that you are using, that how much time approximately it will take, and then you can calculate before surgery only, and you can plan out.
No, sir, I have not come across any such algorithm. But softer stone less than 600 unit dust very easily, take much smaller time. More than 1200 HU need to be, means you need to put in an effort to dust them. They take longer time. So
And certainly the dimensions, sir. If it is like 2 by 1 by 0.5, definitely you can still attempt it. But if it is 2 by 1 by 2, then that is a problem. And
So,
also multiple stones, multiple big stones.
so,
That should not be
so
attempted.
do you recommend to empty the bladder? Because Hiren, you were saying the pressure also increases. So do
Yes,
you
sir. If you
recommend that
are,
we should empty the bladder
sir,
continuous?
if it's going beyond 60 minutes, then definitely yes. But usually, if you have an access sheath and one kidney draining, then the other kidney is already empty. So your irrigation fluid is already coming out, but definitely some fluid comes out also by the side of the access sheath. So it is not a bad idea to have a infant feeding tube inside. But then you are having two tubes in the urethra. So again, it all comes back to that 60-minute rule, sir.
Okay. So can you just tell the students some algorithm that if the stone is hard, stone is then what energy should be used? If it is less than 1000 pound per unit, then what is better? Is there any? Can give the suggestion? So it decreases the temperature, decreases the timing also, and the clearance is better.
We discussed that, sir, that if the stones are hard, we initially like to go with a higher energy and little lower frequency. Even Pankaj sir said that he starts with 1.2 and maybe 10
No, no,
frequency.
no. I don't start with. I was talking of popped fragmentation.
Popped. Yes,
I always start with 0.4 and 30-40, and
yes.
then
That is with
increase or
holmium
reduce
laser.
the
Yeah,
energy and frequency based on how the stone is
correct.
behaving.
Correct.
Sir, to answer your questions, there are few things that in flexible ureteroscopy we must remember. Uh, One, we have discussed about the size and the timing. One more important thing will be try not to work for a very long time in the lower calyx. As far as possible, reposition the stone to a more favorable calyx from lower to a middle or upper calyx. Then there is something called as T-tilt position. So when you are doing the stone fragmentation, you should position the patient in such a way that the calyx that you are working in becomes a dependent calyx, a non-dependent calyx. So say if I am working in a lower calyx of a patient's left kidney, then I would keep the patient head low with left side up. If I'm working in the upper calyx, I would keep the patient slightly head high with again left side up. But so depending on where the stone is, you should change the table movement in a way that whatever you are doing fragmentation or dusting in that calyx, the smaller dust keeps on draining from that calyx. You don't want the dust to get collected in that calyx, because with the collected dust, there is a possibility that fragments hide behind that collected dust, and you would see them only in the post-op CTKV that you do. So giving a patient proper position, a reasonable amount of irrigation, intermittently coming out of that calyx, so that with your scope and irrigation, the dust and fragments also come out in the renal pelvis. So these are some tricks you would do to keep on clearing that dust from that calyx, and so that only the stone remains which you can continue to dust or fragment.
So what are the chances of complication? Whether they are high in the lower calyx because your scope is more flexed and it might cause little more damage to the infundibulum, and even the amount of energy which you are using, it is going to remain in the calyx more often compared to the upper calyx. Is there any study
So
on that
basically,
or
what
your
happens is
experience?
when I'm working in the lower calyx, there is problem both for the stone and for the scope. The longer I keep the scope deflected, I'm stretching the deflection mechanism. So gradually your deflection mechanism would become weaker. So always these scopes start with 270 degrees, but with time it goes to maybe 220, 230 degrees. Beyond that, it doesn't go, because you are stretching that deflection mechanism, it gradually becomes weak. And even when I dust in the lower calyx or fragment in the lower calyx, the fragment clearance, we know from ESWL experience that fragment clearance from lower calyx may not always be very good. So it is best to reposition it in the upper calyx or the middle calyx. Your scope will remain straighter, so deflection is not hampered. And whatever you fragment comes out much faster and better.
So is there any relation of the thing cortex thickness and heat energy and the complication related to that?
Hmm. So no studies, sir, but the thinner cortex would mean poorer function, and poorer function would mean lesser stone fragment evacuation. So in flexible ureteroscopy, major fragments you will pick up, but some amount of fragment clearance should happen spontaneously. So if the kidney is very poorly functioning, hugely dilated, then in these patients, whatever I dust may not come out very well. Again, in a hugely dilated system, moving from one calyx to other calyx becomes difficult. Sometimes the stone fragments get hidden in the folds of the renal, say renal lining. So it is not easy in a dilated system. Like PCNL in a dilated system is easier, but RRS may become slightly tricky in a dilated system.
Yeah, that is you are talking about the clearance of the stone. I'm saying that energy. So if the
So
cortex is
energy does
thin,
not depend on the cortical thickness. It will completely depend on your stone characteristics.
no, but what are the chances of this heat energy going outside the kidney if the cortex is thicker compared to that the cortex is thinner?
So the depth of penetration of holmium laser is 0.3 to 0.4 millimeter. Depth of penetration of TFL is 0.1 to 0.2 millimeter. So only when the cortical thickness is lesser than that, there is a risk of surrounding organ injury. Otherwise, there is no risk, sir. So even if I touch the renal mucosa and fire the holmium laser, at best I am creating a 200 micron by 0.4 millimeter puncture in the mucosa. But that energy would not get delivered beyond the kidney.
So now suppose if we are doing, you are using the laser and by mistake you have touched the kidney, when you will be worried? When can you just explain that whether it is superficial when you think that there is a bleeding or you know when you should be cautious and no now it is little deeper and we have to stop the procedure. Like
So
in
if
a
you are
QRP we know that we have reached to the capsule. So is there any can you give your some suggestion that this is a time now you there are chances that you may create a real complication. Fluid can go outside. It can uh, cause a urinoma or something like that, or bleeding can take place. So this is the time you must stop.
uh, I have not read anything like this, neither I have seen anything like this, sir. But yes, cutting infundibulum is possible. It doesn't usually cause much harm. There can be some adhesions inside the kidney because of previous procedures. They can be easily cut. But obviously, if you are seeing fat anywhere, that would be a big alarm for me. Bleeding is a strict problem, is a big problem, because once there is bleeding and once there are clots, your vision becomes very low. So if there is bleeding, then many times you may need to put a stent, come again after a couple of days when things are much better. Because once if there is a diffuse ooze from the mucosa, it will be very difficult to do that procedure.
So, sir, I have a few comments. So, bleeding can be of two types. One is when you go inside and everything is red, is diffuse bleeding. Either it was congested or you have caused some injury while putting in the access sheet. That happens many times. That we have caused some injury or the guide wire has punctured the PCS. There will be blood inside the kidney. In such a scenario, you have to give very gentle irrigation and wait for a couple of minutes for it to clear out. Second way of clearing the blood is to use a little bit of contrast and see that there is no extravasation, and this contrast helps the blood to settle down. However, if you have hit some vessel while doing infundibular, like doing opening a calaceal diverticulum or something, and you see a spot in the PCS, which you can see, then you may try to just diffuse it by using a laser very distant from the bleeding. You should not touch it. However, this is a very challenging job. It is not easy to focus your laser on that sputter. It has happened that I am seeing a sputter and I have lased it and it has stopped. but it is very dangerous because it may increase the bleeding. And the third type of bleeding is, sir, that you have done some procedure. However, your vision has remained clear, but there is bleeding from the parenchyma, or there is a perinephric hematoma or urinoma. That can also happen in RIRS. Therefore, irrigation and flushing should be very controlled in these cases. I think sir has left, but these were the answers for the bleeding.
Hiren, how do you manage? Sometimes there is air which gets trapped inside the below the stone, or in the lower calyx where the stone is, and because of the parallax, because of the air, the vision is difficult, and
Sir,
fragmentation becomes difficult.
that usually happens when it's an anterior calyx. And whenever it's an anterior calyx, in fact, sir's one case only, he had called me, Gaurang Shah sir, where they were able to see the stone but not able to reach it or fragment it or even basket it. This happens, sir, when we are going on using irrigation, trying to clear that air and trying to reach that stone. In fact, in this we have to do opposite. We have to stop the irrigation and suck out the fluid, and the stone will collapse right in front of you. So that is usually air bubbles are our best friends. It helps us to identify anterior calyxes. And when you are using irrigation in an anterior calyx and when you have deflected down and the stone is there, this is the exact action of the flexible scope. That you are down and you are not able to reach it and you are trying to anteriorly go there. In such a calyx, when the calyx will be full, so the stone will be further away from you.
It
So
keeps
the
on
calyx,
moving.
yes, sir. So that calyx has to completely collapse. For that, sir, you have to stop the irrigation. Then it will come closer to you. It's like, sir, in the olden times when we used to do URS and we could see the stone in the pelvis, but we could not reach it with the laser. Then we would stop the irrigation, allow the kidney to empty a bit, start the outflow, and then the stone would come up towards us. In the olden days, we used to do that with semi-rigid URS. Same thing in flexible. So when it's an anterior lower calyx, now you'll always have that problem. So it is better to suck it out a bit and allow the stone to fall in front of you. Then again use gently a little bit irrigation, fragment it. Again it will become full. Again you'll have to suck it out. 2-3 times you'll have to do that. We have one case, sir. Should we start that case so that we can finish? I think we had a good discussion on lasers. Should we start the case, sir?
I think कोई हरकत नहीं है.
I think you can
Uh,
start the case.
Yes.
I may be joining or I may not be because I'm in a
जी सर.
yeah. Okay.
ब्रिजेश भाई चालू करो. ब्रिजेश. स्वास्तिक ब्रिजेश है क्या?
ब्रिजेश नहीं है, ज्वाइन नहीं है सर.
Hiren, you are muted. Hiren, we can't hear you. No, Hiren, we can't hear you.
Hiren, you can telephone Brijesh and find out what is he doing.
Hiren, we can't hear you.
Pankaj sir,
Yeah, now it's better. Yeah.
Pankaj sir, have you got any presentation for HOLEP?
I had, but I think we have discussed most of the things.
Yes, sir. So Swastik had gone to the EMS, sir. He's just joining in 5 minutes. Brijesh. Any other questions from the students?
No, Hiren, if you know the case, you can start the history.
Swastik,
Yeah, Swastik can start the history, then we can show the presentation.
yes, sir. Yes, sir.
The question is popcorning safe for prolonged duration? So you see, one of the success feature for popcorning is that you should give it adequate time. It is not something which happens very fast. But yes, by prolonged duration, you would mean maybe couple of minutes, hardly. Beyond that, it is usually not needed.
So Swastik has said 30-year-old female patient with right flank pain. Now, how will you proceed? Who's going to answer today? Giriraj? Swastik or Paras, one of you can take the questions because we don't have any volunteers. Anybody volunteering today? Come on, guys. One of you take the case. Any final year students are there? Please take the case.
Yeah, sir, Dr. Paras will be answering. He has unmuted.
Okay. Paras will take the case. Okay, Paras. There's a patient with left, whatever flank pain. So, how will you proceed?
So 30-year-old female with right flank pain. So I
Okay.
would like to elaborate the history. I would like to know more about pain, its onset, duration, progression, aggravating and relieving factor. Was it associated with nausea, vomiting, uh, fever? Was it associated with any hematuria, lithuria? What is the character of the pain? I would also like to inquire about any history of previous urethral instrumentation, uh,
Why
any uh,
urethral?
uh, any instrumentation in past.
But how will urethral instrumentation cause flank pain?
So previous instrumentation in past history, I want.
So means, why is that relevant? I still didn't understand.
Uh, the previous instrumentations can lead to strictures. It can.
Oh, you mean previous any say endocrinological
Yes, yes.
procedures? Okay.
So, sir was right. You should not say urethral instrumentation. Any previous history of URS or stone surgery or anything like that.
You see, even Foley catheterization would be a urethral instrumentation.
Correct. Okay, Brijesh has joined. So, Brijesh, he is wanting you to elaborate on the complaints of pain.
Yes, sir.
Yeah.
So patient was asymptomatic before 15 days. When she developed pain or right flank region, pain was colic in nature, sudden onset radiating to the back, gradually progressive and is increased in 10 days. To associate with nausea and vomiting, no any specific aggravating or relieving factors. She also had a hematuria since 2 days, which was intermittent, complete type, and not associated with the passage of clots.
Okay, Paras, anything else you want to know?
So, any past history, any comorbidities, personal history, and
So there was
Tell
no
him.
any history of lithuria, no any history of catheterization, no any history of instrumentation, no jaundice or no any bleeding disorders. She was not having any comorbidities, and this was the past history.
Okay, so nothing contributory. Now what, Paras?
so according to the history, a sudden onset pain in a young 29-year-old female, the most probable diagnosis is urolithiasis. I would like to examine the patient, general examination as well as systemic.
Only one diagnosis.
So, sudden onset pain, no. It can also be due to any obstructive uropathy like PUJ obstruction, or it can be because of any very rarely renal mass.
So when you say uropathy, it's a very important term. You have to use it very carefully. You can say pelvic junction obstruction. Don't say obstructive uropathy.
Okay.
Okay, now what will you
Yes.
do? Somebody is asking, why can't it be a clot colic or a diabetic papillary fall off?
Patient is having no comorbidities. Here.
No problem.
There are two important things which we have missed in this history taking. One is whenever there is a hematuria, one thing we should understand is whether it's a painful hematuria or a painless, means is it associated with upper tract pain at the time of hematuria. And second, in a young lady, always concentrate on the menstrual history. So you could land into a huge trouble by missing menstrual history.
Absolutely.
She was having regular menses, and her menstrual history was insignificant, sir. She didn't have any menorrhagia.
What sir is saying that she's not having menses at present.
Yes.
You see, you should, there is nothing like non-significant menstrual history. What we are interested in is when was the last, what was the LMP, last menstrual period date? Because there is a theoretical possibility of any 29-year-old lady who is married to get pregnant. And if with the diagnosis of stone, you are likely to ask some radiological investigations. So knowing when the last period was is important to just to document.
Yes, sir.
ठीक है जी, आगे बढ़े.
So abdominal examination was normal, sir. No any abnormal findings were noted. On inspection palpation, there was no any tenderness, no any palpable lump, hernia orifices were normal, abdomen was soft, and renal angle dullness was present.
Now, Paras, what do you want?
So I would like to examine the, I would like to investigate the patients. I would like to do a urine routine microscopy, culture sensitivity. Since there is hematuria, I would also like to do a cytology. I would like to do a complete blood count, serum electrolytes level, serum creatinine, blood urea nitrogen, and RBS, USG, KUB as an extension of my examination.
But would you like to do cytology when there is hematuria?
No, no. After the hematuria clip.
So first time this young lady comes to you with flank pain and hematuria, and in your first consultation, you would advise her cytology.
The rest of the things you asked was routine. So, you could first see an ultrasound, and if it's simply a stone or something, why would you go for cytology?
Every patient with hematuria does not need cytology.
Okay, sir.
Dr. Gite, your comments on this?
Sir, it is absolutely blunder to do a cytology.
Absolutely. मला वाटतं तुम्हाला झोप येईल म्हणून तुम्हाला उठवलं जाईल.
Hematuria is there or not doesn't matter.
Absolutely.
Your primary diagnosis is urolithiasis. Rule out the urolithiasis and then think about others.
Other causes. Absolutely.
So, rule out means simple. That's what I said. Just do a sonography first. Whenever this patient comes to OPD, what will you ask? Urine routine, sonography, and routine investigation, CBC, creatinine. Creatinine also you will ask because you maybe want to do further investigation. So in the same blood count, it will be done. Do think what you're doing routinely, Paras. Okay? चलो बताइए उनको जी नॉर्मल इन्वेस्टिगेशन बताइए.
Yeah, so this was the urine routine examination.
हाँ.
We also had sent culture. Culture came out to be negative.
Okay. Ultrasound.
This was the blood reports. Her hemoglobin was 11.1. WBC count was 9,000. Create was 0.7. Electrolytes were within normal range. And her HbA1c as a routine she had already done from outside, it was 5.2.
She is non-diabetic, no?
Yes, sir, non-diabetic.
Yeah. So, okay. Go ahead with the ultrasound.
So this was the sonography. Sonography showed there is slight enlargement of the right kidney with an evidence of 4.8 mm calculus at pelvic-ureteric junction. And right-sided kidney showed very mild hydronephrotic changes due to calculus. Left kidney was normal, sir. Urinary bladder was also normal. And uterus was slightly bulky. And, the measurements of uterus were within normal range.
You don't have the images?
No, sir.
बोलो जी पारस भाई.
I would like a CT urography.
Why CT urography?
Why do you want urography?
Best investigation for patient is in colic. Which investigation?
Plain CT KUBs, NCCT.
So if you are tell in exam directly NCCT KUB, is it wrong or right? This patient present in colic. Your diagnosis is hopefully ureteric stone. So if you want to do a sonography, then why not sonography and KUB combined? Yield is more. X-ray KUB. These are simple questions you encounter in exam. And you should be ready with your answers or your defense.
You understood now what sir has said?
Yes.
So in patient coming with colic in emergency, the choices are only sonography, sonography plus X-ray KUB or NCCT. Which will you choose and why?
So, if CT is available, then non-contrast CT KUB I will choose as my first.
So why? Sir has asked you why.
No, but first you already chose sonography, na? So why don't you defend your sonography? Just because sir asked the question, now you jump to CT.
So USG as an extension of my examination.
So then say that no, you are there in the casualty. Maybe sonography is available. Patient has come in EMS. At least you know by screening, you know what it is, whether it is stone. You're thinking some malignancy, something you're thinking. So if you have said sonography, certainly don't jump because examiner is asking NCCT.
True.
You justify that you have done sonography.
You have done a NCCT, and now this patient had a pregnancy test positive.
You must
So-
always stand by what you said.
So
You said
doing
sonography.
a sonography is not a wrong thing, but you
Correct.
should have defended it with your own defense. So
Absolutely.
ideal investigation for patient in ureteric colic guideline wise is NCCT KUB. But if your history is in doubt, समझो फॉर एग्जांपल सर ने जैसा बोला कि प्रेगनेंसी का कुछ डाउट है या अदर कुछ पैथोलॉजी का कंफ्यूजन है तुम्हारे इसमें कि भाई स्टोन के बजाय और कुछ रहने का चांस है, तो या क्लिनिकल तुम्हारे पास रूटीनली क्लिनिकल एग्जामिनेशन का एक्सटेंशन बोल के सोनोग्राफी दैट इज वन ऑफ द रीजन यूजुअली गिवन इन एग्जाम, ये अगर बोला है तो उसको डिफेंस करना है.
बराबर है. Second question sir asked is sonography and X-ray KUB. So you can say that I have asked about the menstrual history. She's not pregnant, and sonography and X-ray KUB are complementary to each other. However, sensitivity and specificity of both are 70 to 80%. So definitely NCCT KUB for urolithiasis has got 99% sensitivity and specificity.
The majority
something-
times the lower ureter cannot be violated. There are a lot
Correct.
of gaseous reverberations.
Correct. And this 4.8 millimeter stone may be missed on X-ray KUB.
Exactly. नहीं,
So all
सोनोग्राफी
this
का भी
is-
ऑपरेटर डिपेंडेंट है, बहुत सारे प्रॉब्लम्स है सर.
This is
लेकिन
the way you have to talk in exam. Main thing is to talk. You started with sonography, continue with sonography. Talk about the X-ray KUB, talk about the CT, talk about the menstrues that you have confirmed that she is not pregnant.
sonography is a simple, easily available, but operator dependent as an extension of clinical examination, which will guide for doing the further investigation. That will my defense in
Absolutely.
exam. If I have told the sonography, if I have told NCCT, I will take help of guidelines, and as per the guidelines, CT is available in my institute. We are routinely doing the NCCT KV for ureteric colic. That is my defense.
Okay, Paras.
Yes, sir.
पंकज सर कुछ ऐड करना है तो और कर दो.
नहीं साहब, बिल्कुल सही बोला आपने. The thing is that there is ample number of studies which have compared sonography to CT KUB, NCCT KUB in emergency, and they have found that either has equal say results as far as predicting the need for intervention is concerned. So if you look at need for intervention and the risk of patient coming back to emergency again with pain, that prediction is equal with both. But yes, CT has an advantage of picking up smaller stones. CT has an advantage of picking up ureteric stone, does not need preparation, not observer dependent, can help you identify other pathologies. So CT has its advantages, with a disadvantage being cost and radiation exposure.
Perinephric fat standing, urinoma, complications, any other associated pathology, everything will come with CT. चलो बताइए ब्रिजेश भाई, CT क्या किया है?
वो पहला वाला इमेज, हाँ ये इमेज रहने दो. Yeah,
Yes,
please read the
Paras.
city.
So this is a excretely reconstructed film showing radio opacity in the right pew junction with mild mild to moderate PCS fullness.
Opposite kidney is functioning normally.
Continuous function.
Now what will you do? Patient will say, sir, I have got a small stone which is there in the upper ureter. And will it come out?
Uh, I would like to know the size.
He said ना 4.8. CT में क्या size है ब्रिजेश भाई? CT report पढ़िए.
Right kidney is 9.4 cross 4.7 centimeter. Evidence of calculus for 5.4 cross 3.8 mm of 990 units at periureteric junction causing mild hydronephrosis and a mild proximal periureteric patch stranding is noted. Left kidney is normal. Uterus is slightly bulky.
चलो जी, now you know the size. Now what will you do?
So I would like to advise a medical expulsion therapy for the first line of treatment, and if it fails, then I would advise for RARS.
So what is medical expulsion therapy, beta? Is it for pew junction stone?
Upper ureter stone are more likely to get passed if they are less than 6 mm.
So are there any studies to say what are the chances of upper ureteric, mid ureteric, low ureteric stone expulsion? What will you tell the patient? And those studies are done for what size of stone? What are the percentages? What are the pros and cons? What can happen? When will you intervene? Or will you not intervene? How much time will you wait?
Exact studies
Are you aware of
Anybody?
any nomograms which predict stone expulsion, spontaneous stone expulsion?
What conservative treatment you want to give? Paras,
yes, sir.
what conservative treatment or what drug treatment you want to give?
So I would like to give analgesics. I would like to start an antibiotic. I would hydrate the patient. I would start an alpha blocker.
So alpha blocker, where is the alpha receptor more common?
Hello.
Where is the alpha receptor more common in the urinary system?
Paras.
मेरा हेडफोन एक मिनट चालू होएगा.
बड़ा है नहीं है.
Hello.
Hello.
हाँ पारस. सर पूछ रहे थे where are the alpha receptors located?
Sir,
Paras, have you logged in with two computers?
sir, they are located in the mostly in the trigonal area near VUJ.
So then where is the stone?
Sir, the PUJ.
So then you were talking about medical expulsion therapy. Where is the Urimex going to act?
Is alpha
Hello.
receptor still present in the pelvis and upper ureter?
Hello.
Is
Paras.
alpha receptors present in upper ureter and pelvis? And how much is the distribution? Is there any study shows using of alpha blockers for a stone in the pelvis and upper ureter?
Are you there, Paras? You're muted.
No, sir. I am using Swastik's phone.
हाँ ठीक है तो sir is asking are there any alpha receptors in the pelvis and the upper ureter?
So they will relieve the obstruction at the lower level. So it may help in facilitating the stone passage.
वो ठीक है but sir is asking distribution of alpha
Where
receptors.
is the obstruction in lower ureter? What is obstructing lower ureter? Your answer is right, but you need to defend your answer.
What will happen to the
Let
stone?
me
Paras?
rephrase. What is the indication of giving? Which stones will you give alpha blockers as MET?
So stone less than 6 mm in size.
So
They are more
if there is a
likely to
2 millimeter lower ureteric stone, will you give MET?
2 millimeter lower. So if the patient is having no symptoms of sepsis, there is no urinoma or there is no signs of pyelonephritis, then we can go for MET.
For a 2 millimeter stone?
Yes. 2.
Internal diameter of the ureter is 6 millimeter on average, and at constriction site it is a 4 millimeter to 5 millimeter, like PUJ, iliac crossing, and VUJ. If the stone is less than that and if it is not impacted, then what is the role of alpha blocker? It will pass spontaneously without doing any treatment, and the credit will be taken by n number of people, including you and me.
No, you see, you can't blunder in colic treatment. Remember, MET is indicated only for stones larger than 5 millimeter. They are not indicated for smaller than 5 millimeter. So anywhere between 5 to 10 millimeter, and MET works better for lower ureter, though it can be given for stones anywhere in the ureter. So anywhere in the ureter for a similar size stone with alpha blocker, without alpha blocker, the spontaneous stone clearance rate is higher when alpha blocker is given. But do not give MET for stones smaller than 5 millimeters, because they are as it is, as sir said, they are as it is likely to come out on their own. So they don't need additional medical support for that. So there are few very good review articles on this. You must read those articles as to what are the different MET drugs, which one to be used in which indications. So never say MET for a 2 millimeter stone. It is not indicated.
So sometimes Paras examiners may ask you questions, the answer of which you may be telling correctly, but then you get confused and you stop. The first question I asked you is the MET indicated in upper ureteric stone, you kept quiet. Pankaj sir said, no, it can be given anywhere for any stone, but you have to explain it. How?
Sir, distribution of the
Second question was whether it will work for 2 mm stone. Then you have to justify about the diameter of the ureter. And then Gite sir asked you about the distribution of alpha blockers. That's what sir is talking now.
distribution of the alpha receptors starts from prostatic urethra, that is prostate, and right up to the pelvis there are alpha receptors. But when as you go above, the number is very less and less.
The concentration of alpha receptors reduces.
Yes.
Correct.
So the impact of alpha blocker on a upper ureteric or pelvic stone, if it may be 4 millimeter or 5 millimeter, if you are say expecting that alpha blocker will act on that stone, the amount of distance he has to travel from pelvis to the lower ureter is very long. So that's why majority studies are in the lower ureteric stone 6 millimeter to 8 millimeter, 8 millimeter to 1 centimeter or more than 1 centimeter. Comparative study है और नॉन कंपेरेटिव है, तो वही एरिया में ज्यादा स्टडीज हुए वाले हैं. तो ये स्टोन के लिए स्टार्ट विथ मेडिकल एक्सपेंसिव थेरेपी इज नॉट गुड आइडिया.
And again, you see, you will come in huge difficulty if I start asking you why you started antibiotic.
Exactly.
What is the role of antibiotic in this patient?
Your culture is negative.
Patient doesn't have fever, the total
Count is normal.
CRP is 10, culture is
TL
negative. There is no
TLC
renal
normal.
tenderness.
So there is hydronephrosis. There can be increased pressure.
So how does antibiotic help there?
Since sir, there is stasis, there are high chances of there can be chances of infection.
So you are giving as a suppressive dose,
So
preventive
prophylactic.
dose.
Yes.
No, beta, there is absolutely no role of antibiotic in this situation.
Okay.
Okay. The indications of antibiotic are obviously associated fever, raised total count or raised CRP, clinically renal tenderness, and patient running fever and other features of sepsis.
Somebody has asked for fat stranding.
Okay, what is the significance of fat stranding?
So they are suggestive of pyelonephritis.
No, they are not suggestive of pyelonephritis.
Inflammation, extra renal.
What is stranding? What exactly happens in stranding? स्ट्रैंडिंग मतलब हो क्या रहा है वहां पर?
Fats coagulate, necrosis.
नहीं भाई, इसको थोड़ा कोलिक और अपर ट्रैक्ट ऑब्स्ट्रक्शन को ठीक से पढ़िए.
See what can happen in a simple case. You think that it is a 5 mm stone and it is a very simple case. See what can happen, Paras. Basics में रड़ा हो रहा है.
Fat stranding is not coagulative necrosis. If you give such answer, there is no way I can ask you about, what is wet stranding, what is dry stranding. There are so many things in stranding also. Yes, Rupam has given a slightly correct answer. So this is basically pylolymphatic backflow because of high pressure in the pelvic collection system.
Absolutely.
Okay. So this only suggests obstruction, acute obstruction. So you will not see fat stranding in a PU junction obstruction because it's a very slow obstruction.
Okay. Yes.
And there is no coagulative necrosis there. And fat stranding is not an indication for antibiotics. Okay, when you say hydration means what advice will you give to the patient?
So I ask the patient to drink about 2 to 3 liter water.
He will start vomiting. पेशेंट कोलिक में है, उसको 3 लीटर पिला दिया तो उल्टा शुरू कर देंगे.
Paras, you must be seeing so many colics in your emergency. What do you tell those patients?
Just tell us what you will do. This patient came to casualty. उतना ही बोल दो. 2 लीटर 3 लीटर पानी पीने के लिए बोलेंगे क्या उसको?
I will get IV analgesics to relieve the pain. I will start IV hydration and a dose of alpha blocker.
What is the indication of IV hydration?
So if there are if there is a lot of vomiting, if there is any dehydration,
Yes. So
I'm
does this patient have vomiting in our history? No.
no.
So what is the role of IV hydration then?
He has just come with mild pain, ना? तुम ऐसे क्यों कर रहे हो?
Rather, IV hydration is contraindicated. Tell me, what are the drawbacks of giving IV hydration?
So it would further increase the tubular pressure, and
So when you
it will
know that,
further
why are you
cause
giving
decrease
IV
in JF.
hydration? There are even reports of fornical tear because of excessive
Yeah.
IV hydration.
In RJ only we had reported a case.
Yes. So this IV hydrotherapy or IV overhydration is absolutely not to be done. It should be done only if patient cannot tolerate oral liquids.
It is commonly done in our nice family doctors' clinics, which should be done so cautiously. It's not a good thing to do. If patient
Old,
is sick, is vomiting and not retaining anything, then yes,
olden concept of hydrotherapy is now completely absolute
out,
and scientific.
out, out.
Yeah.
It is dissuaded. You don't do it.
Yes, sir.
It will cause harm. You see, the stone clearance happens by peristaltic activity of the ureter. If you suddenly infuse the patient with lot of fluids, there will be a column of urine which stands over the stone, which will hamper the peristalsis. Rather, instead of helping stone clear, it will
Reduce.
prevent the stone from coming out. And as it is, once one kidney gets obstructed, what happens to the vascularity of that kidney in acute obstruction?
So initially the GFR will try to normalize. Later on, the GFR will fall.
No, I asked you what happens to the vascularity.
उसका आंसर, अगर सपोज एक्यूट कोलिक में रेनल वेसल को क्या होता है, आईवीपी कर दिया समझो फॉर एग्जांपल, तो किडनी किडनी दिखेगी नहीं दिखेगी कभी कभी?
सर नहीं दिखेगी.
क्यों?
नो आईवीपी आपने किया तो उसके पिक्चर को क्या कहते हैं? अगर कोलिक में आईवीपी किया तो उसको क्या कहते हैं? व्हाट इज सीन देयर?
एंड व्हाई इट इज लाइक दैट?
Dense.
It is called as a delayed dense nephrogram. Okay, so the contrast remains, means it is just the parenchyma which gets opacified and the density gradually increases with time. There is no opacification of the pelvic system there. So it is just a nephrogram. And that is because of the changes in the vascularity because of acute obstruction. So if you give IV fluids there, less water will get filtered from this kidney, more water will get filtered from the normal kidney. So giving IV hydration is of no use.
Is there some experiment? Obstruction का experiment?
One experiment, gold bladder.
That's correct. Gallbladder kidney, gallbladder single
clip.
kidney, I am forgetting the names now. You should know that better. You tell us. चलिए ठीक है. So this patient, shall we come back to the case, Hiren?
Yes, sir.
Yes, sir.
So you have given him alpha blocker and oral analgesics. You have discharged the patient home. Patient is comfortable. How will be your follow-up in this patient? The pain has stopped.
So I would like to Do a sonography after about a 1 week time
What is the intention of doing sonography?
to see if there is any passage of stone, resolution of the hydronephrosis, or there is stone migration.
Yes. So you want to see the movement of the stone, whether the stone is going down the ureter. Now we have done the sonography, the hydronephrosis and stone is at the same place, but patient has no pain.
At the same time, you will also advise the patient that during this 1 week, if something happens, if he develops vomiting, pain, fever, then he has to come back. These three words you have to always remember.
So patient has remained asymptomatic, but the stone has also remained at the same place without increasing hydronephrosis. What next?
So since I would like to then give a surgical management to the patient. I will
So is
switch to
there any
from
time now? Because you have waited for 1 week, but patient is saying, sir, I'm fine. I'll wait for 1 more week. It's a catch-22 situation.
so,
Bolo.
Four,
so we
four
can
millimeter,
wait up to 3 weeks.
4 millimeter stone after 1 week of your treatment still is in the renal pelvis. What are the probable pathologies there? Why that stone has not come down?
Correct.
You are expecting that small stone should come down, provided that that kidney should be functioning. One number. Any other thing? So suppose kidney already some associated pathology की वजह से functioning नहीं आएगा, वो यूरिन प्रोड्यूस नहीं होगा तो नीचे नहीं आएगा. दैट इज रेयर पॉसिबिलिटी. तो ऐसे बहुत सारे पैथोलॉजिकल चीजें दिमाग में सोचना चाहिए कि वो नीचे क्यों नहीं आ रहा. 1 हफ्ता हो गया, वो जब तुम सोचेंगे तब उसका सर के क्वेश्चन का आंसर मिलेगा कि भाई और आगे क्या करना.
So there can be any PUJ obstruction there, or the stone may be speculated. There may be a mucosal edema.
No. There is no question of can be. Is it there?
So in CT, it was a round stone. I cannot see any speculation.
So are you suspecting P junction obstruction in this patient?
No.
Why?
So in the CT film, there is no the coning of the pad
See
at the
what
PUJ.
you are talking. Be careful, Paras. Your exam going. Can you, sir, asked you about can there be any P junction obstruction? You're talking about CT.
Please show that CT again if possible.
And with the stone there, can you talk about obstruction?
Now, does this patient have PU junction obstruction on right side?
No.
So why? Why are you saying no? Where will be the secondary stones? If there is a PU junction obstruction, then stones will be called as secondary stones.
Yes.
So where will be the secondary stones? Will they be stuck in the PUJ?
They will be in the calyx.
They will be free floating.
So there will be multiple stones,
So
round
multiple
stones,
free floating round stones, only then suspect distal obstruction. When the stone is sitting in the PUJ, there is no PUJ obstruction.
And you should not comment on CT. Even if there is a doubt later on, you have to do a renal scan or something and comment it. And like sir said, firstly the stone is in the PUJ, no?
Shali, now patient has waited for 2 more weeks. The stone has moved maybe 1 centimeters down. Patient is still asymptomatic, no pain, no fever. He's taken alpha blocker and your lifestyle advice. Now he's also fed up of doing repeated sonographies. He wants the stone removed. What will be your advice?
So for a upper ureter stone, I would like to counsel the patient about URS, and I will also like to counsel about if the stone is pushed in kidney, then I would like to do a RARS with degestanting.
Which URS you want to do?
Sir,
Which
which
URS? Upper ureteric stone, 4 millimeter. Which URS?
so
How many URSs are there?
Which
Right.
type of ureteroscope you use? RIRS is another option you told.
yes,
What type of ureteroscope? What size of
semi.
ureteroscope?
So we use semi-rigid URS. 4.56 French.
So is that semi-rigid ureteroscope is made for upper ureter? Suppose that stone went back in the lower calyx. What you will do with 4.5 French semi-rigid ureteroscope?
Then RIRS.
So what will be the best treatment in this patient?
Flexible URS.
So first you have to calibrate the ureter. Na? So you will use a 6 by 7.5 French URS scope. If you reach it and you're seeing the stone, maybe you can basket it and laser it. But if it goes up, then you know at least the ureter is good for you to put a flexible scope. Same steps what you are doing, that only you have to tell, no?
No, isolated ureteroscopy. Sorry, ureteroscopy with isolated use of semi-rigid ureteroscope in upper ureter. Practically, a number of people are doing, but theoretically, answer is wrong.
Correct.
Yes.
Upper ureter and kidney stones, flexible is the right way to go.
So, by the step of flexible ureteroscopy, as you told, if you are using
Calibration.
the same
Yeah.
for dilatation, if you reach there, stone is in front of you. If you want to fragment the stone with pneumatic or laser, जो भी हो कर सकते तो करो. That is a part of flexible ureteroscope.
Correct, sir. Calibration.
So ideal
चलो.
answer for patient is आप दोनों बता दो जो भी. मुझे तो लगता है RIRS will be the ideal answer. अगर आपको नहीं चाहिए RIRS का अवेलेबल नहीं है, मिनी PCNL, माइक्रो PCNL, या नंबर ऑफ टाइप ऑफ
छोटा stone है sir, ESWL also if it is available.
Yes, you should
Exactly.
first talk of ESWL here.
First ESWL.
वो भी कर सकते हैं. हॉस्पिटल यूनिट कितना है वो हमने डिस्कस किया है नहीं. हॉस्पिटल यूनिट अगर
990 है, but it's 5
Also has
millimeters, sir. 990 है, but 5 millimeter stone है.
कर सकते हैं. ट्रायल ऑफ ESWL is also a good idea.
You see,
चलो जी ब्रिजेश भाई बताइए क्या हुआ था. Sir was saying something. Sorry.
in your whatever, whenever you are seeing a stone patient in exam, don't forget ESWL.
Yes, sir.
For kidney stones and upper ureteric stones, except lower calyx stones, ESWL is something which you should keep in mind before going to flexible ureteroscopy.
And especially in pediatric and younger patients, they have good kidney function.
And
She's
this 5
29
millimeter stone would means all you need to do is even if it breaks into a couple of pieces, the job is
Yeah,
done.
2000 shocks will be enough. 29-year-old girl.
Yes.
Sir, how much time, sir, we have to wait, sir, medical expulsion, sir, if patient is asymptomatic?
You see, if patient is asymptomatic, you can wait any amount of time as long as there is no increasing hydronephrosis, no infection, and patient is comfortable.
And
But
patient
if
is
something
compliant.
doesn't move within 2 to 3 weeks, the possibility of that stone moving is very less. So then waiting may not give you benefit. So tomorrow I am a jiddi patient and I say mujhe rukna hai. If I don't have pain and fever, and if you wait, you are not causing any harm to me as long as I come back to you the moment I have got pain or fever. But if
Compliance.
over
They
2
forget
weeks you
about it.
feel the stone has not moved, then you are justified in. If stone keeps on moving 2 centimeters every week and patient remains asymptomatic, you are justified in waiting longer. If not anything, this will come down in the lower ureter, and instead of flexible ureteroscopy, you will be able to treat him with a rigid ureteroscopy.
The problem is compliance. They are lost, to follow up. Sometimes the pain disappears, they forget about it. 6 months later, kidney is fired.
So, sir, if in exams, medical expulsion therapy, sir, how much size stone we should say?
So more than 5 millimeters and less than 10 millimeters, you should keep MET in mind. Okay. But simultaneously, you should also keep on adding that if the stone is in the upper ureter and stone is more than 8 millimeter, the success rate is lower. But it is still worth trying if the patient is motivated and wants to give it a medical trial.
I think one paper said 60, 40, 60, 50, 40. That's how the percentage goes from down to up. 6 millimeter lower ureter, then 6 millimeter mid ureter, 6 millimeter upper ureter.
So, and if the patient is symptomatic, then also we can.
Symptomatic meaning if he has pain, fever, vomiting, you have to intervene, no?
You see,
Only pain if the
fever
pain
and
is severe.
sepsis will be absolute indications for intervention.
Yes, yes.
And pain, if it is so severe which doesn't get managed by your day-to-day medications, then obviously you need to do something.
Still it is indication for intervention. Remittent pain not responding to the medical treatment.
Yes.
It is indication for intervention.
Correct.
Absolutely.
Correct.
Okay.
What was done, Brijesh?
Sir, first they did URS with 4.5 scope, and stone was pushed back, and then they did RIRS because when they tried to do TFL, stone was getting pushed back in the pelvic cells. So then they did flexible RIR.
Chalo. We had a good discussion today. Gaurang Shah sir will say, I was not there and you people went on.
No, I am there. I am on a cruise. I am on a cruise. You can see it. And still I have attended with all the West Zone urologists.
Regards
with
to
me.
everybody, sir.
Yes.
सर ऐसा
I
न
don't know
करे,
whether you
वेकेशन
can.
पर है तो वेकेशन ले सर.
But there are something called commitment. So I thought that I will listen to all of you.
No sir,
I'm
अभी
not
मैडम का
talking between.
कमिटमेंट निपटाइए, अभी वेकेशन लीजिए.
Okay. I hope you are able to see.
Very
Yes,
well,
sir.
sir.
You are looking nice. Enjoy.
Okay. Bye.
Bye, sir. Bye. Good night, everybody.
Bye.
Well done,
And
boys.
thanks to all of you for doing such a fantastic
Yes,
Zoom clinic. Thank you.
thank you, sir. Well done, Giriraj. Well done, Paras, Swastik, Brijesh, all of you. And please volunteer to take some questions. Every time same people are presenting.
Boys, before we sign off, I just want to say that pathophysiology of acute obstruction and management of colic, इसमें गलती will be unexcusable in exam.
Yes, sir.
So please read it well, discuss among yourself. This is very, very important. And keep your ideas very clear on these two topics.
Absolutely.
Agreed, sir. Good night, sir.
Chale, sir.
Good night, sir. Good night. Good night, everybody. Good night, Pankaj, sir.
Good night.
Thank you. Good night, Gite, sir.